So thank you for watching my talk. I'm going to talk about the pre-existing mental disorder clinical profile, inpatient services and costs in people hospitalised following traumatic spinal injury. So before I begin, I would like to acknowledge the Aboriginal and Torres Strait Islander people as the traditional custodians of this land, whose culture is the oldest living culture in human history. Specifically, I'd like to acknowledge the Bidjigal and Gadigal clans who traditionally occupied the areas of where the Black Dog Institute, where I'm recording from, is situated. I'd like to pay my respects to elders past and present, and I'd also like to extend that respect to any Aboriginal and Torres Strait Islander people here today. I'd like to acknowledge my co-authors as well here on the screen and appreciate the different contributions from their specialty areas, health economics, psychology, social work, trauma services, epidemiology, and we've worked together to really look at the importance of this issue and then what can collectively be done with the findings. So let's look at what traumatic spinal injuries are. They include spinal column fractures and spinal cord injury, or both. The leading causes of TSIs are falls and motor vehicle crashes, and they're among the most severe injuries with potentially long-term physical, psychological, and social consequences. Injury can be a consequence of mental disorder. Mental illness and substance use are known to significantly increase all injury risk. And both new and prevalent mental disorders are among the leading causes of non-fatal burden of disease and are escalating globally. The physical health disparities associated with mental disorders impose substantial economic impacts that are population-wide. Substance use disorder commonly co-occurs with mental illness and social exclusion, which are associated with significant health inequalities, including markedly increased rates of death from injury. Furthermore, individuals with pre-existing mental illness are at increased risk of substance use disorder after traumatic injury, which likely complicates treatment and recovery. On the screen, you can see a Canadian study that looked at across the country injury presentations to EDs and individuals with presenting in the context of alcohol overuse were more than 4 times likely to report intentional injury. Add substance use disorder to that presentation and they're almost 18 times more likely to report intentional injury than those reporting no substance use. So the social determinants of mental disorder as well as social determinants of health are fairly prevalent. Injury is also a cause of mental disorder. And we know that among patients with traumatic spinal cord injury, for example, they have an increased risk of severe physical complications after injury of not only the normal physical complications, but self-harm and self-neglect. One of my co-authors here has conducted studies looking at spinal cord injury patients in the first 12 months after injury, and by 12 months, more than 40% of them exhibited mental illness, with alcohol use being one of the most common comorbidities. We also know that the compensation system can be significantly stressful and add an additional burden on top of everything else that these individuals are experiencing, adding stress, financial difficulties, and that impacts on their mental well-being as well. Particularly the fact that from injury, most commonly post-injury service provision focuses on the physical consequences. However, we know that targeted multidisciplinary clinical management in acute settings can reduce the burden of injury of mental disorders and physical consequences of mental disorders. But it needs early identification and prompt referrals to specialist and allied health professional care for traumatic injury patients, which can improve mental health outcomes. However, there is evidence that the health service is really not capable at its current resource levels of responding to the encumbrance of need. So the aims of this study, therefore, were to describe in an incidence of populations with, describing a population of incident traumatic spinal injury, the incidence of pre-existing mental disorder in that population across New South Wales, Australia, and determine whether these patients are at higher risk of complication and a more costly course than spinal trauma, without these comorbid conditions, and then have a look at the allied health service management of these patients and the impact on the inpatient stay. So using a whole of population record linkage data across New South Wales, the study periods 2013 to 16, and we ascertained the comorbid mental illness substance use disorder or dual diagnosis using ICD-10 codes, and specifically as noted there, and then the costs using activity-based funding data. So the results, the cohort was over 13,000 individuals in that period of time, and then within that, 21% of these individuals had pre-existing mental disorder, so roughly similar to the general population. However, we noticed that compared to those without pre-existing mental disorder, these individuals were more likely to be older, to have fallen or to have self-harmed, to have a higher injury level, and to have comorbid injury on admission, and also to have a spinal cord injury, which is the most severe among those injuries. So regression analysis, we conducted a fractional response beta regression model, fitting that to the dependent variable of the injury severity score, and using the ISIS, International Classification of Injury Severity, and then using those covariates to adjust, looked at the impact of the different covariates on injury severity as an outcome variable, and conditioned on the predictive variables, the mean injury severity was at least 5.5% worse in individuals with pre-existing mental disorder. So they have higher injury severity compared to the rest of the population with the same injury adjusted for relevant covariates. Then looking at the impact of the injury on length of stay and the other covariates. So the negative binomial regression model was fitted, and we saw that in individuals with dual diagnosis, they experienced a almost 2 times higher length of stay compared with individuals with no mental disorder. So requiring significantly increased resource. They also have much higher risk of complications. And all of this speaks to really what's happening in that acute setting. So the measure of resource then required in the acute setting here showed that we can see here that the costs, length of stay is significantly elevated, which is closely related to costs. And in those with dual diagnosis, which was, I think 7% of this population, the costs are, and length of stay is really markedly greater than other individuals. So equally a much higher risk of inpatient complications, which again will link to then length of stay. And complications we looked at were infections, urinary tract infections, wound infections, and the like. So, and then if we look at individuals who have TSI and comorbid mental disorder, if they were intentionally self-harming, then they have 4.5 times greater length of stay than those without any diagnosis, and greater length of experience of complications. So then we wanted to look at what was documented within the APDC data with the ICD codes, and use the procedure codes to pull out referrals to inpatient allied health, particularly psychologists and social workers, who you would think would be part of the non-physical health assistance in that, that vulnerable population. So we can see here that the rates were fairly low, particularly comparing individuals with dual diagnosis. Only 7% with dual diagnosis saw a social worker and psychologist, compared with 39% of individuals with no mental disorder who saw a social worker and a psychologist, which speaks to the level of health literacy, advocacy, also the SES measured by the Bureau of Statistics CEFA score, which looks at the index of economic advantage to disadvantage. So those in the higher SES range were far more likely to have access to and have documented psychologists and social work, which again, coming back to social determinants of health and the differences that we can see there. So the strengths and limitations of this paper are that we had access to whole of population cohort data with robust cohort identification and based on previous work. However, we didn't have access to the ambulatory mental health care data or the, for example, Medicare better access data as well to see what was happening outside the hospital setting. But the implications for practice are really that acute care inpatient services need to systematically identify and address mental health issues in injury patients as part of routine care. So comprehensive multidisciplinary care responses must really address the social determinants of physical and mental health in injury presentations. And this would hopefully reduce the economic burden on the Australian Health Service additionally. So what next? The paper is published, so certainly feel free to look that up. We're conducting further analysis to have a look at then post the acute care admission, so looking at readmissions, unplanned readmissions, the extent of that in mental disorder individuals with mental disorder compared to the remainder of the population, and doing a follow-up over a couple of years to see what happens in that setting. Then putting the pieces together and hopefully making some recommendations for acute setting practice. So thank you again to my co-authors. Thank you very much for watching, and I hope you're enjoying the conference. Thank you very much.